Thank you. It's good to be here with Professor Ramadori and Professor Roskam. We have been together, in this field for the longest time. And thank you for the invitation to this webinar. Also, I have a colleague here, Daniela Sia from Mount Sinai, that will talk to us about the molecular study of primary liver cancer. So in this talk, I would like to summarize what are the most common mimickers of hepatocellular carcinoma that the regular pathologists, as Tanya mentioned, outside the academic pathology departments have problem in diagnosing. And the question very often is, can this be a hepatocellular carcinoma? Especially, can this be a well-differentiated hepatocellular carcinoma? And with that, I will start with the list of the most common question that these lesions turn out to be focal nodular hyperplasia, hepatocellular adenoma in a non-cirrhotic liver. And in cirrhotic liver, it can be large regenerative nodule, or as mentioned earlier, this spastic nodule, which can be separated into a low-grade and high-grade dysplastic nodule. The other one that always seems to be a problem is Angiomyel lipoma. It's not a very common entity. However, it's often misdiagnosed as hepatocellular carcinoma. Focal fatty sparing in a liver that is having a fatty liver, severe fatty liver, an area in which the fat was not present, may look on imaging as a lesion or a mass and will be biopsied, and that also could be a problem because very often the hepatocytes are kind of hyperplastic in that area. The other thing is primary liver carcinomas, such as mentioned earlier also, the intrahepatic cholangiocarcinoma. If the biopsy is obtained from the periphery of the tumor, very often the tumor cells kind of arrange in a trabecular pattern and therefore mistaken as a hepatocellular carcinoma. For metastatic tumors, of course, immunohistochemical studies are very helpful. The one that has morphologies very similar to HCC would be renal cell carcinoma and also adrenal cell carcinoma. I remember my mentor, Dr. Hans Popper. At the time, of course, there was no immunohistochemistry, and he always mentioned when you make a diagnosis on a small liver biopsy as hepatocellular carcinoma, always put a disclaimer that renal cell carcinoma or adrenal carcinoma cannot be completely ruled out. So helpful information, and before we, of course, we try to look at the biopsy specimen without any information, but this kind of information would be very helpful in making the final diagnosis. For example, the clinical information, I always, in any biopsy, I would start with the age of the patient, the gender, the associated diseases and constitutional symptoms, and also the information about the lesion itself that was seen on imaging, the size of the lesion, the number of the lesion, and the location of the lesion. Are they spread on both lobes, or it's just clustered in one lobe, and so forth? And also rate of growth, if there is imaging to compare. And at the end, I always stress that team approach is the best for the patient. Of course, the team will include surgeon, hepatologists, radiologists, and pathologists. So how about focal nodular hyperplasia? It's such a clear entity. However, it seems to still give some problem to pathologists. This focal nodular hyperplasia is slightly more in women, 20 to 50 years, not associated with cirrhosis or oral contraceptive steroids, often associated with vascular abnormalities and hemangioma. Information about the lesion would be very often the lesion is solitary and subcapsular in location. They can be multiple, and then the differential diagnosis of hepatocellular adenoma would come into the picture. Imaging studies, if the central scar, which is typical for the lesion, is seen, then may not need a biopsy. And I think certain imaging studies can differentiate FNH from hepatocellular adenoma, which I will leave to Vincent. So this is a morphologic, the gross macro picture of focal nodular hyperplasia, very typical. One you cut the specimen and you see the central scar, the diagnosis is made. On a microscopic level, you can see that within the scar, you see very abnormal and multiple arteries, vessels, but in the absence of the similar size bile duct. So we know that this is not representing a large portal tract. And from the central scar, as you can see here on the trichrome stain, you still see the multiple abdominal vessels, but spreading out from the central scar are the fibrous septa, and sometimes, especially closer to the central scar, you will see nodules. Without any information that this is a lesion, it may get diagnosed as a cirrhotic liver. The farther from the central scar, of course, the fibrous septa become thinner and then disappear. And if the biopsy is from the periphery of the lesion, it may, again, difficult to pin out as the diagnosis as FNH. However, now we have this very powerful tool of immunostaining for glutamine synthetase. Normally, glutamine synthetase is expressed by the hepatocyte next to the central vein or central venous. This is the portal tract, and so always just the in zone 3. In FNH, the pattern of staining change, and this is what we call map-like pattern and a diagnostic for FNH. So this is as I mentioned, very specific and helpful immunohistochemical stain to confirm the diagnosis of FNH. Of course, very often the FNH has to be differentiated from hepatocellular adenoma. This is another lesion that on when the imaging studies cannot confirm exactly whether this is a malignant or benign lesion. It's biopsied, and of course nowadays is for subtyping of the adenoma. As you know, adenoma is mainly in women, often associated with oral contraceptive steroids. This depends on the duration, the potency, and the type related the type of steroid that is given. Other causes include androgenic steroids, glycogen storage disease. There is an F1 alpha inactivation and maturity onset diabetes of the young type 3, metabolic syndrome, and NASH has been now associated with adenomatosis. And this lesion in the patient present as abdominal mass, abdominal pain, or hemorrhage, which cause acute abdomen or shock. Diagnosis again can be done by imaging and biopsy. This is, of course, an old picture. As you can see, hepatocellular adenoma, large, and as you can see, with quite a bit of hemorrhage. But nowadays, with the so much progression in the imaging techniques, that these lesions are diagnosed in much smaller sizes before they bled. And the histology, the hepatocyte, the lesional hepatocyte almost look like normal hepatocytes. Sometimes you can see they are really hyperplastic, that range in 2 cell thick, but not usually more than 3. And inside adenoma, as you can see here, there are a lot of these abnormal vessels with thin wall, hence causing this easily bleeding lesion. There is a very nice work that correlates the mutations in different adenomas with the morphology as well as the immunohistochemical staining results, pioneered by the French pathologists and molecular experts. And so we can now use morphology and immunopathology to subtype hepatocellular adenoma. Why do we need to subtype them? Because there are different risks of developing HCC in adenoma, as well as the risk for bleeding is more in one of the subtype, which is the unclassified with the ASS mutation. So I will start with the first one, which is the H type. In this subtype, the adenoma has an F1 alpha mutation. It represents the large number of adenomas. Most cases show, as you can see here, steatosis. And the diagnosis is confirmed once we know that it's an adenoma, that the liver fatty acid binding protein is not expressed in the lesion. As you can see here, liver fatty acid binding protein is normally expressed in the hepatocyte, but not in the lesion. So this is confirming the SNF1 alpha mutation. The association with HCC is uncommon, but not, but it's seen that as a group, I think we had collected 7 or 9 the H-type adenoma with which has malignant transformation. And actually, one of the patient always keep calling me and ask me, does he have to be follow up by imaging every 6 months? And it's very difficult for me. And I said, why don't you call your surgeon or your doctor? He said, no, my surgeon told me to call you because I was one of the authors in this paper. And so it's difficult because it's not common. But in men, of course, any adenoma has higher risk for developing HCC. So probably this doctor is a male, and he need to be closely follow up as well. In this type, very often there is a liver adenomatosis. By definition, it's more than 10 adenomas in the liver. The second one is the beta-catenin mutation. In less than 10% of adenoma, again, you see it more in men than in women. There is overexpression of the two targeted genes, the glutamine synthetase and GPR49 is associated with cytological and architectural atypia. Cytological, as mentioned earlier, also is the pseudoglandular formation, more than 3 cells thick, and also small cells chains. The architectural atypia is a nodule within a nodule, and sometimes it's not easy because HCC that develop in adenoma very often is well differentiated, such as this one. I find that the CD34 is helpful. Glypican-3, when it's positive, of course, it's helpful. The nuclear beta-catenin and also the glutamine synthetase would be very helpful. The beta-catenin is nuclear instead of membranous. You can see here quite a bit of vessels and hemorrhage, dilatation of the so-called sinusoids in this lesion, and this what I think make the imaging mimicking the HCC. So glutamine synthetase, as you can see here in the normal liver, just centrilobular, but very strong and diffuse within the lesion that has transformed obviously into partially into HCC. The third one is the inflammatory adenoma. In this case, it's a 56-year-old man with NASH. That's a risk factor for inflammatory adenoma. The 4.5 lesion in segment 8 and another one, smaller one in segment 6. So this is how it looks like on the H&E. This is a 44.5 centimeters, so it starts already to have hemorrhages. And as you can see here, this is staining for serum amyloid A, SAA, and how to interpret this staining sometimes it's difficult because it causes a lot of background. But if you have a non-lesional liver, then it's much easier because it has to be much stronger than the non-lesional liver. In this case, this is the same lesion, and you can see that in some area the cells are too cell thick, and in other area it's more than 3 and more. Thick trabeculae, the glutamine synthetase, this is also described to have high risk for malignancy, is the starry sky, strong patchy distribution of the glutamine synthetase within the lesion. The CD34, as I mentioned earlier, can be helpful. They are diffuse, and in this case, in the area where there is HCC transformation, you can see the nuclear expression of the beta-catenin. So beta-catenin can occur in an inflammatory adenoma as well as in the H-type adenoma. It can be very focal, but we have to look very carefully. So those are the two that are often the pathologists have questioned, can this be HCC? And the others are the nodular lesions in chronic liver disease. And these, as I mentioned, I think earlier, include macro or large regenerative nodules, low-grade dysplastic nodules, high-grade dysplastic nodules, and hepatocellular carcinoma. This was in a paper by the International Working Party that was published in 1995. So this is an example of macroregenerative nodules in which the large nodules are multiple and actually almost occupying the entire liver, seen, for example, in a patient with autoimmune hepatitis that has been treated, and therefore the septa had become thinner, but regeneration is very good, and therefore you see all these large nodules. Not necessarily they are pre-neoplastic, and that's why HCC in autoimmune hepatitis with cirrhosis is not very common. And how about the dysplastic nodules? These are nodules. The diagnosis of dysplastic nodules, of course, is made on gross examination, but I'm sure also on imaging as a lesion, but not as a dysplastic nodule. The nodules should be 0.6 or 0.8 centimeter or larger. It has to be in a cirrhotic liver, and they are different in color, texture, and degree of bulging from the cut surface, and it's bulged more than the rest of the cirrhotic nodules. So this is an example of low-grade dysplastic nodule. This one, see, the color is different. It bulged more than the cirrhotic nodules, and if you examine under the microscope, it may have a very small fibrosis around because it's compressing the porta tract and the fibrous septum. Yeah, it still contains porta tracts. On this trichome, you can see the small porta tracts, and as not normal cytology, large cell chains may be present. It's not the large cell chains is not a pre-malignant sign, and there is no nodule within nodule or no architectural atypia. This is different than high-grade dysplastic nodule, which is considered pre-neoplastic. Actually, once a biopsy diagnosed high-grade dysplastic nodule, the lesion will be, if possible, be ablated without really looking for the clear-cut malignant transformation. This is an example of this high-grade dysplastic nodule. Within it, you can see that there is a nodule within nodule with different color, and this one, of course, had become the hepatocellular carcinoma. Here on the whole mound, you can also see the nodule in this area. If the biopsy comes, the needle is in this area, it will not hit the HCC. So should be deeper. If the biopsy specimen is obtained from the deeper part, then the diagnosis of HCC can be made. So in high-grade dysplastic nodule, there are no or rare porta tracts. There are cellular atypia. It may store iron, for example, more than the rest, or actually not storing iron when the rest of the liver is full of iron. The architectural atypia is a nodule within nodule. There is increase in mitosis and proliferation, and also increase in arterioles and capillaries. And this would make the high-grade dysplastic nodule detectable on imaging. This is an example of the nodule within nodule again. You can see that cirrhotic nodule are not containing too much iron. The high-grade dysplastic nodule is very brown, so it has gained its own autonomy. And within the cirrhotic dysplastic nodule, you can see that the HCC again is excluding iron. So this you will know that it's already there is a malignant transformation. The last one that I wanted to discuss is this case, a 36-year-old woman with hepatic mass, clinical diagnosis, possible adenoma, and the lesion was resected. So this is how the lesion looked like, very well circumscribed, and the histology looked like this one. Again, compressed hepatocyte. The tumor cells are arranged in trabeculae. This is another biopsy that we received just a month ago. It was sent by outside hospital with the question of looking like a well-differentiated HCC, but why all the hepatocyte markers were negative. So this is the higher magnification. As you can see, they really look like HCC almost, but you can see that not quite look like hepatocytes. So when you do the staining, of course, the keratin K818 stain very nicely the surrounding hepatocytes, but not the lesion. And it's MB45 or melanin marker, or the other one is melan A, strongly positive within the tumor. So this is a angiomyolipoma without much of the lipoma, so it's more like myo. So angiomyolipoma has a female predominance with the mean age around 50. In 10% of the patient have tuberous sclerosis. There is association also with the renal angiomyolipoma, and presentation is usually incidental or acute ruptures or bleeding. In most of we collected as a group many cases, but in these cases there were no recurrent, about 30 cases, no recurrence in the follow-up. However, as always, Professor Tanya Roskam is always the pioneer, and she had published the first malignant angiomyolipoma of the liver, and followed by some other publication. So as a summary, I just wanted to say that mimickers of HCC do exist. It gives problems to pathologists, but also I think at the radiological level, there are mimickers for HCC. If I think that one is not sure, it always can be referred to a more pathologists that have more expertise in and have looked at more liver specimens on this kind of entities. At the histopathological level, immunohistochemistry, and now of course molecular studies are very helpful in confirming what the tumors are. And I always stress on the team approach if we still don't know. So in this case, it's almost look like HCC, but this is of course a neuroendocrine tumor. The problem was solved with the immunohistochemistry, and this one was look like HCC, but this actually is the periphery of a classical cholangiocarcinoma. And if you look carefully, the trabeculae is not separated by sinusoids, but by this very thin fibrous tissue, and of course it's strongly positive for CK7. Thank you.
Okay, thank you very much, Swan. It was a very interesting overview of benign lesions or metastatic lesions that can mimic hepatocellular carcinoma. And it, of course, stresses that taking biopsies and have a histological confirmation of the nature of the tumor, that it's really, really important. Otherwise, we treat benign tumors as malignant tumors, and of course, then the results of the treatment are very, very good because you have to start with a benign tumor. So I don't know whether there is any question from the audience for Professor Thung.
I have a question for you, Tanya, actually.
Okay.
But, no, yeah. For some time, I think the interventional radiologists or the surgeons, they treat the tumor without even biopsy, especially if it's LIRAT 5 and above. But nowadays we are back to the old days, which is good, you know. They
that's very good.
Before they treat, because they want to have the biomarkers, you know, for the tumor.
Yeah, that's indeed one of the reasons why they need the biomarkers in the tissue for the molecular profiling and the genetic profiling of the tumors. But at the same time, at least in our institute, and I'm sure in Mount Sinai too, still the clinicians were really convinced that histopathology really is necessary to characterize a tumor, to have these problems of differential diagnosis solved. But I also think it's very good that you stressed the teamwork, which is so important in oncology. Okay, Giuliano, you still have a question?
Yeah, I just want to add, you also need experienced pathologists.
Yes, that's true. That was also stressed by Swan, that, each has his own specialty, which is, of course, you have general pathologists and you have more specialized ones. And in this setting, it's indeed not easy to know all these different, the whole spectrum of liver cancers and liver tumors. So, okay.